My name is Erik Mittra. I'm an assistant professor in nuclear medicine and radiology. And I want to thank everyone, just like these prior speakers did, for being here today and allowing us to share this information with you. I also specifically want to thank Dr. Kunz and Dr. Fisher for inviting me to speak. As she mentioned, that I, along with Dr. Kunz, are actually the co-PIs of the PRRT trial at Stanford, and actually Dr. Yaguru and Dr. Fisher are also co-investigators. So my goal in the next few minutes is to talk a little bit about PRRT and what it is and give you a little bit of background on it historically, as well as talk about what the current trial in the United States and Europe is all about. So that's what I'm going to do. And I know you've already seen a few of this information already from the prior speakers, but I think that the information is complex enough that it doesn't hurt to probably hear it a couple of times. So on the top left, you're seeing an image, again, of this somatostatin receptor that Dr. Fisher mentioned. And that is really what allows these types of neuroendocrine tumors to grow and expand, and equally what allows us to target the therapy against these types of tumors. The middle image there on the left-hand side shows a staining for that type of somatostatin receptor, so typically what a pathologist might look at. Oh, thank you, actually. Okay. And then I think one of the key images here is this bottom left here. So this is the actual molecule of the human somatostatin, which is 14 amino acids long. So each of these little circles you're seeing are amino acids. And then this agent, the octreotide, which is used as the kind of standard chemotherapy for this type of tumor, you can see is just an 8 amino acid long segment of that exact same human somatostatin molecule. So that is really how you get the targeting to allow you to treat these types of tumors which express somatostatin receptors. Now, if you look on the right-hand side, all of this, what is showing you is all of the stuff that we've subsequently developed in terms of imaging and therapy for neuroendocrine tumors based on that type of targeting with somatostatin. So once again, at the top left is this human somatostatin molecule, the same as this one, and this one on the right is the same as this one, as the sandostatin molecule. And then what you'll see is that the main difference that we have subsequently done is to attach a linker here. So either DTPA or DOTA, which they stand for long chemical names, that's why we use those terms. And then attached to that linker is a radionuclide. So a radionuclide is any type of unstable isotope which is releasing some type of radiation, either gamma radiation or in terms of treatment, beta radiation. So the one you see here is the octreoscan molecule. This is the one that's been used for a long time for imaging and what Dr. Yaguru talked about in the prior talk. And then the one on the bottom right is the DOTA-linked gallium-68, which is the PET agent, which again Dr. Yaguru talked about. So these are the two that are used for imaging. And then these two here are the ones that are used for therapy. So you can see that it's really the exact same molecule once again, but now using this DOTA linker either to yttrium-90 or to lutetium-177. Now these actually emit beta radiation, which allows us to actually kill the cells that it targets to. So that's a general concept I think that's very important to understand, is in this whole field of imaging and therapy is all based around this human somatostatin molecule, which Dr. Fisher talked about, and then attaching various radionuclides to it to allow us to either look at the tumors or to treat the tumors. So these are some more images of the octreoscan, which again you're probably pretty familiar with, showing how easily you can evaluate the whole body for evidence of metastatic disease. You can then follow the patient and see how well they're doing in response to the therapy. And then in this particular case, unfortunately, the patient subsequently also had a recurrence. But again, just showing how easily you can do this type of thing. And the focus of Dr. Yaguru's talk on the prior talk was to show how this can then be transformed with PET imaging. My goal, again, is to talk about peptide radioreceptor radionuclide therapy. So that's what PRRT, once again, stands for. And the goal of it, just to reiterate one more time, is that it's this trivalent compound here, which is the combination of the actual localizing agent, which is the somatostatin analog, combined to this chelator, which we talked about is DOTA in terms of the actual therapy form, and then the radionuclide, which can either be yttrium-90 or lutetium-177. So this molecule is shown in much more complex form here, also shown by Dr. Yaguru. And then historically, here's what we have, is that initially the idea of this therapy actually came about from the same agent that was used for imaging. So this indium-111 molecule, which is the one that's the octreoscan agent, can also be used for therapy if given in very large doses, can actually release a different type of radiation that can have some therapeutic benefit to it. And the initial studies for that were actually done in the late 1990s, so quite a long time ago. And those studies showed that, in fact, there was some symptomatic benefit for the patients, but there wasn't really too much of a long-term survival benefit or progression-free survival benefit. So then the subsequent analogs that came out were the two that are mentioned below, and they were really allowed because the linker changed from DTPA to DOTA. And because of that, you could either attach yttrium-90 or lutetium-177. So the yttrium-90 was the first one that was started, and that was really in the very late 1990s and really in the early 2000s that the first clinical trials were done with that. And then in the late 2000s is the lutetium-177. These two compounds are very similar to each other, and there have been many, many clinical trials comparing the two agents to each other. And for the most part, I think a general good take-home message is they work with generally good similar efficacy. One difference is that the yttrium-90 has a much higher energy and can therefore actually be said to be able to treat larger tumors better because it will travel further in tissue. And then the lutetium-177 has a slightly lower energy and therefore is said to be better for smaller tumors because you also don't want the radiation to go too far outside the tumor and affect normal tissue as well, which would lead to some of the side effects for this type of treatment. So as I mentioned, there have been many studies done on these types of different therapies. I was just actually reviewing it this morning as I was having breakfast, and I was kind of shocked by how many different things have been done. Primarily, as Dr. Yaguru mentioned, this has been done for a long time, mostly in Europe. And then I'm going to transition to talk about the US trial next. But this is just one example of one of the earlier studies that were done, and just to show you why people are very excited about these types of therapies. So in this particular study, it showed that there was an increase in progression-free survival to 44 months using this type of PRRT compared to only 15 months with the sandostatin molecule. And equally, there was an increase in overall survival to about 6 years compared to 3.5 years compared to sandostatin. And also, there have been several studies to show that the quality of life and all the symptoms that we talked about with the syndrome associated with neuroendocrine tumors is also reduced with these therapies. So that's why there's a lot of excitement about PRRT. So now if I transition to where we are in the United States in particular with this type of therapy, the molecule we're talking about now is Lutathera. That's the other name that you might know it by, which is the brand name from the company. So it is, once again, the lutetium-177 octreotide molecule. So it is a somatostatin analog, and it's really targeted in most of these clinical trials. It has been looked at in various different types of neuroendocrine tumors, primarily though focusing on these gastroenteropancreatic neuroendocrine tumors that Dr. Fisher talked about as one of the perhaps older names for these types of tumors, but in this literature, that's a common name that comes across there. And so the targeting of this Lutathera agent, again, acts by the somatostatin receptor, and then you deliver that beta radiation, high-dose radiation to those cells, which then interact primarily with the DNA and cellular mechanisms within the cell and kill off those cells, and that's how it works. So it's targeting both the receptor, which by itself works because sandostatin, that's how that works, and then in addition to that, you have killing effect of the radiation. So the current clinical trial is called NETTER-1, that stands for NET therapy, and is the first trial in a large multi-center approach. That's why it's called NETTER-1. And it's put together, the sponsor is Advanced Accelerator Applications, which is based in Europe. So it's an international multi-center trial. There's 14 sites in the US, and there's 28 sites in the European Union. And the eligibility for this study, and there's a complex a list of eligibility requirements and ineligibility issues as well, but just to summarize briefly for this thing, the goal is to enroll patients who have inoperable, first of all, progressive, octreoscan positive, well-differentiated neuroendocrine tumors of the midgut or small bowel. And the the patients should have already been treated for a period of time with 20 to 30 milligrams of octreotide, and then they're continuing to progress on that dose. Okay, so there's a lot of terminology in there, but I think based on the information you've had from the prior two lectures, I think these terms should make sense. So once again, it's inoperable, meaning you can't just go in and take out the primary tumor. It has to have been progressing on octreotide, a stable dose of octreotide already, and it has to be octreoscan positive. That's important because it needs to show that the somatostatin receptors are still there and active. That's how, again, this therapy is going to localize to that particular tumor site. And it needs to be well-differentiated NET. So the primary objective of this study is really to look at progression-free survival and compare the Lutathera to high-dose octreotide LAR. So I'll talk about those two arms of this study in 1 second. First, I'm just going to point out these are the clinical sites in the US that you might be wondering where they're located. So you can see that vast majority are kind of in the Midwest to East Coast side of things. So on the West Coast, there's actually only 2 sites, which is here and then Cedars-Sinai in Los Angeles. And all of these sites are more or less on the same path, meaning that no one site is particularly far ahead than the other one. We've all essentially come on board with this trial this year, and we may have enrolled a couple of patients and treated a couple of patients, but nobody is too far ahead than another one. So I mentioned that there are 2 arms to this study, and this is a graphic kind of summarizes that. So arm 1 shown at the top and arm 2 shown at the bottom. This is not meant to signify that arm 1 is more important in any way than arm 2. They're both very important pieces of information that this clinical trial is trying to assess. So arm 1 is with the Lutathera agent, and the way that it works essentially is that you get 4 separate administrations of the Lutathera compound and 4 separate visits that occur 8 weeks plus or minus 1 week apart. And in addition to that, you also get some octreotide as well, long-acting octreotide, and that's primarily to help with symptom control. And that long-acting octreotide, which is still the lower dose of 30 milligrams, continues for several months after the Lutathera has already completed. Now the second arm, which is the high-dose octreotide arm, there the idea is that we give a much higher dose of the octreotide, double what you would normally give. So as I mentioned, the patients to be even enrolled have to already be on 20 to 30 milligrams, so now we're giving 60 milligrams, and then that's given over the same duration of time as the other arm overall time is. So really the goal is 2 things, to see if a higher dose octreotide can help with this type of patient control, and conversely, does the radioactivity help differently, and to compare those 2. So I hope that makes sense. Here's again a little bit more detail about the Lutathera side, because it's probably a little bit more complex and unknown to you. So as I mentioned, it's given as 4 separate injections of the Lutathera for a total dose of 800 millicuries. These are again based on those many studies that have been done previously in Europe looking at the dose effectiveness of this type of therapy. It's a little bit complex because in addition to the Lutathera infusion, which happens over 30 minutes, you also need to get an infusion of amino acids. So the amino acid infusion is just it looks like a saline bag, which then goes in through an IV. That is very important to help protect the kidneys. It's been shown that the infusion of amino acids helps that the radioactivity from the somatostatin analog doesn't stick around in the kidneys. We talk in nuclear medicine about dose-limiting toxicity, meaning which organs will get the highest dose and therefore may have other side effects which would prevent you from getting a therapy benefit from the compound itself to your cancer. And the 2 dose-limiting organs are the kidneys and then the bone marrow. So in terms of helping prevent that radiation from sticking to the kidneys, that's why you need to get the amino acid compound. The amino acid compound is started half an hour before starting the Lutathera, and then it's given for an additional 3.5 to 4 hours after the Lutathera is done. So if you kind of put all this together, by the time you would come to nuclear medicine, get an IV placed, you would take some anti-nausea medication initially, then start the amino acids, then start the Lutathera, then continue the amino acids. You're pretty much there for the vast majority of the day. At the end of the day, though, you're emitting not too much radiation, and there's not a huge amount of radiation safety precautions to talk about. I won't go into that in great detail. I'm happy to answer some questions either at the panel discussion at the end or afterwards if any of you do have questions about that. But there's definitely some radiation precautions, and you either may have to be admitted to the hospital for one night, or if you live locally, then certainly you could go home. The next morning you would come back for a low-dose octreotide injection as well, and that completes the first cycle of the therapy, and then you would repeat that in 8 weeks. Okay, so that's actually everything that I wanted to cover, and I'm once again happy to take any questions, but at this point we'll transfer it over to Josh Mailman. Thank you.